think we'll get started. So good morning, everybody. Welcome to our GIS 5th edition. And it's our pleasure to have you with us. And I wish that we spend a good 3 days with expensive of a lot of educational material. We'll start our first session. It's going to be about acute coronary syndrome. And I have my pleasure to have great panelists with me, Dr. Abdullah Shihab, Dr. Adil Riyami, Dr. Imad Shaban, Dr. Khalid bin Thani, and Dr. Musa Akbar. And we'll invite our first speaker, Dr. Abdullah Esmaiel. He's from Mubarak Kabir Hospital in Kuwait, interventional cardiology and structural interventional cardiologist, and he will talk to us about spontaneous coronary dissection during ACS.
Let me see my slides. Assalamu alaikum wa rahmatullah. Good morning, everybody. So, SCAD and ACS. Let's start with the basics. What is SCAD? What is SCAD? So, we all know that the 3 layers of an artery, intima, media, and adventitia. SCAD is when you have a subintimal bleed. And there are 2 hypotheses for SCAD, the inside-out hypothesis and the outside-in hypothesis. The inside-out hypothesis is when you have a tear in the intima and blood leaking to the subintimal space, and thereby increasing the pressure on the false lumen and causing compression and impairment of flow. The outside-in hypothesis is when you have a microvessel rupture, followed by increased pressure on the false lumen, and this can result in fenestration or leak into the true lumen or not. And this is the strongest hypothesis approved by imaging, by OCT imaging, when we have, in fact, most of cases of SCAD have no fenestration, which is type 2 SCAD. We're going to come to that in a second. Most commonly, it affects women, 90% of cases in women. We don't know the exact incidence. It's anywhere between 1 to 4%, and can affect 10% of cases can happen in men. It accounts for 10 to 25% of cases in ACS in pregnancy and 25 to 60% of cases postpartum period. How do they present? All of them present with ACS. 25% present as an ST elevation MI and 75% present as a non-ST elevation MI. And there's around, I'll say, 8 to 10% present with VT, VFib. To diagnose it, you need a coronary angiogram. There's no other way to diagnose it, although we all know that it carries an increased risk of catheter-induced dissection. The risk of catheter-induced dissection with SCAD is around 3 to 4%, where it's 0.2% in the general population. Therefore, we should pay attention to our technique during these angiograms. I personally suggest that I always start with a non-selective injection. If I have a female patient in the right age group, I'm suspecting SCAD, I always go with non-selective injection of the RCA and the left main. And then when I'm happy that there's nothing in the ostium, then I engage and try to be coaxial as much as possible. And also there are some experts that recommend femoral access rather than radial access in SCAD patients, because you have better control and stability of the catheter and hopefully reducing the risk of catheter-induced dissections. This is an angiographic classification of SCAD. This is a hand drawing by Jackie So, the world leader in SCAD, which then translated to be the most widely adopted classification of SCAD. There are 3 types of SCAD. In fact, there are 4 types of SCADs. I'll call them 3+1. This angiographic images will demonstrate them. A is type 1 SCAD, is when you have double lumen appearance, and it accounts for 25% of cases, and we have the double lumen appearance because of the fenestration between the true and the false lumen, and then leak of contrast from the true to the false lumen. Followed by type 2 SCAD. Type 2 SCAD is divided into type 2A and type 2B, where you have diffuse narrowing. If you see in B, you have normal caliber vessel, followed by diffuse narrowing, and then normal caliber vessel. This is a type 2A SCAD, what we call it regain of normal caliber. So diffuse narrowing and then regain of normal caliber. Whereas type 2B SCAD is you have diffuse narrowing without regain of normal caliber. D is type 3 SCAD, and I think we all agree that it mimics atherosclerosis, and it's hard to differentiate between that and atherosclerosis. And E is type 4 SCAD. Type 4 SCAD is when you have total distal occlusion. Now in terms of vessels affected, usually SCAD affects the LAD. It accounts for 45% of cases, followed by the CIRC, around 30%, and the RCA is 25%. And the most affected segments of the LAD is the mid to distal segments. Sometimes you can have multi-vessel SCAD, like in F. And you can see here on the OM, you have normal caliber, diffuse narrowing, and then regain of normal caliber, which is type 2A SCAD. And the same thing here, you have normal caliber, diffuse narrowing, and then regain of normal caliber. But there are cases of SCAD that you cannot really classify it. You cannot put it in any of these categories. Like B, for example. In B, you have normal caliber, diffuse narrowing, and regain of normal caliber, but also you can see there's some contrast staining here, which is a feature of type 1 SCAD. So you have kind of mixed picture of different types of SCAD. The main pathophysiological distinction between the different types of SCAD is whether or not you have fenestration between the false and the true lumen, and that has an implication on the treatment strategies. So type 1 SCAD has a fenestration and has the best prognosis in terms of complication with PCI and lower risk of early and in-hospital events. Be careful with SCAD mimickers. Sometimes you see some contrast streaming. It appears like type 1 SCAD. Just by increasing the contrast injection pressure, you have totally normal vessel. Sometimes you can have coronary spasm, so you should always give nitroglycerin, intracoronary nitroglycerin, and need to make sure there is complete resolution and normal-looking vessel before you can exclude SCAD. Catheter-induced dissection, my biggest fear when cathing young females in their 40s and 50s coming with chest pain. If you don't do selective injection a non-selective injection before your coronary angiogram, and you see this, you won't be happy. You don't know if you caused this or the patient came with that. So you always start with a non-selective injection. You see the diffuse narrowing of the vessel. This patient had SCAD. It's a different patient. And finally, atherosclerosis is the most common mimicker of SCAD. Now, if you have your diagnosis, very good, excellent. You don't have to do anything else, especially if the patient is pain-free and the territory affected is small. In these cases, less is more. Don't instrument the coronaries. Don't do anything else. But if you are not sure about the diagnosis, then you may want to confirm it. The only way to confirm that is by doing intracoronary imaging. And although theoretically intracoronary imaging carries risk with a patient who has coronary artery dissection, it's not a prohibitive risk. So when you have diagnosis dilemma, you're not sure, it's okay to do coronary intravascular imaging. There's a retrospective study of 63 patients undergoing OCT imaging for SCAD patients, and only five out of the 63 patients had complications related to that, but none of them had adverse clinical outcome. 2 of them ended up with stenting. But no catastrophe, that's what I mean. This research work done by my good friend and colleague, Dr. Ali Slamy, during his fellowship, looking at intracoronary imaging for diagnosis of SCAD safety. They look retrospectively at OCT images, and they have 36 patients, 3 out of the 36 patients, that 8% had complications related to OCT with the SCAD patients. So is it OCT or IVUS? Theoretically, IVUS is very appealing. You don't need to give contrast. You don't need to inject, but it has low spatial resolution. So OCT is the imaging modality of choice in SCAD patient. You can see here in A, where you have true lumen and false lumen with no fenestration between the false and true. You can see in D, there is fenestration between the false and true. And E and F, the wire is in the false lumen in both images, and the true lumen is compressed. Pregnancy-related SCAD, very malignant phenotype, more proximal, more extensive dissection, but it doesn't change our strategy. You start with a diagnostic angiogram. Even in pregnancy, the risk is acceptable because we need to make a diagnosis. You can try to limit the images, change your angiographic views, but you have to make a diagnosis and you have to treat it. Most patients can be treated conservatively, and as I said, it mostly affects the mid-distal LAD. If it's only the distal LAD and the patient is pain-free, don't do anything during the angiogram, don't instrument it, just treat it medically. But what if if the patient is in shock, if the left main is dissected, if there is large territory affected, then in this case, we have to do an intervention. We have to revascularize, and the revascularization options that we have are PCI and CABG. So let's start with PCI. I think if you are planning to do PCI, you have to be extremely careful with your wiring. You need to go with soft workhorse wire, avoid the polymer jacketed wires. I think it should always be with imaging, because if you stent into the false lumen, it's going to be a catastrophe. There are certain CTO techniques that sometimes people do in CTOs, have a microcatheter, aspirate, see if there's blood, say, okay, I'm happy, I'm the true lumen. I don't think that applies in SCAD patients, because the pathophysiology that you have a hematoma in the false lumen. So maybe you're aspirating the false lumen and then you will end up there. If you don't image it, it's a problem. A study of 63 OCT SCAD cases, in 5 cases, at least one run was in the false lumen. So if you want to do PCI, you have to do it with imaging. This paper looked at the SCAD patient that underwent PCI. Most of them ended up with stenting. Some of them also had cutting balloon, 1 or 2 stents in most of the patients, and the most affected segment, or stented segment, I should say, is the LAD. Important technical aspects in PCI. Again, this is all based on experts' opinion, and there is no solid data to support any of that. First thing is cutting balloon angioplasty. As we said, that the best prognosis is with type 1 SCAD, and type 1 SCAD has fenestration between the false and the true lumen. Thereby, we feel that if we decompress the hematoma and creating fenestration between the false and true lumen, we will have better outcomes with stenting. Thereby, that's why we use cutting balloon angioplasty. But we should be careful and use it at low pressure. Sometimes wiring may be enough, or just PUBA will be enough. If you have good flow after that, you may decide to stop. If you decide to stent, you have to pay attention that you may extend the hematoma. So try to do that with a single stent only, single long stent. Try to cover 5 to 10 millimeter proximal and distal. That's why you kind of distribute the hematoma. Because if we see here, if you see this case, mid to distal LAD is affected, the stent was placed, then the hematoma extended more proximally, and we ended up with very extensive, or they ended up with very extensive stenting. Outcomes of, and one important point regarding stenting, it's not, you should change the way we think about stenting in SCAD compared to atherosclerosis. In atherosclerosis, we always look for angiographic success and complete angiographic success, and we want everything to be beautiful. And in SCAD patient, it's okay to leave some dissections behind. The idea is to restore flow. The idea is just to restore flow, because most of that will heal with time. CABG is the last resort, is if you feel that PCI is extremely high risk, or if you fail PCI. The problem with CABG is that you have to get the graft in the distal to the dissection. You have to do it quick, and you need the graft with high flow, and it has high rate of graft failure. So maybe saphenous vein grafts are the best grafts for that, because with time this dissection will heal and the graft will fail. Medical treatment, thrombolytics is not recommended, but it's not like if sometimes, you know, maybe patient received it by mistake, it doesn't end up with a disaster. Like there are certain reports about patients who received the thrombolysis with SCAD with no adverse outcome. It's not recommended, but if it's done, it's not a disaster. Anticoagulation as per standard procedure for coronary angiogram. Antiplatelets, the antiplatelet duration is controversial. Everybody agrees on dual antiplatelet, or most people agrees on dual antiplatelets for 2 to 4 weeks, and then continuing aspirin. The duration of aspirin, is it long-term aspirin, is it 4 years? It's controversial. There's a single underpowered Canadian observation trial which showed no increase in risk or no reduction in events with long-term aspirin. What's important is blood pressure control and beta blockers. Beta blockers being shown to reduce your risk of SCAD and good blood pressure control as well. No role for ACE inhibitors or statin unless you are hypertensive or you have LV dysfunction or you're dyslipidemic. Recurrent SCAD, it's anywhere between 5 to 15%, and what increases your risk of recurrence is increased tortuosity, FMD, history of migraine, uncontrolled hypertension, and non-use of beta blockers. Thank you very much.
Thank you very much, Dr. Abdullah. It's a great presentation. So from audience, anyone have a question or a comment, please, there's a lot of mics stand. So
do you use CT scan to diagnose, Dr. Abdullah? Do you use CT role in assessment for...
CT, yeah. Okay. So the CT will not be diagnostic for SCAD because, as we said, it mostly affects the mid to distal segments and it has low spatial resolution. I think CT can help you if you have a proximal SCAD, and it will help you to follow up healing for proximal SCAD. So it's not recommended routinely to do CT for follow-up. If you have a proximal SCAD that you did not interfere on and you want to follow up and to ensure healing, it's helpful. Otherwise, it's not. There's no role for CT.
Great. Dr. Deep?
Thank you so much for this nice overview. Last year meeting, I presented actually a real case of spontaneous dissection in a 40-year-old lady with total occlusion of the LAD. And I need to hear from you your comments about using the stent in dissection. This was a total occluded vessel. You said it is better to use one stent and leave some dissection. This is regardless of the flow, or you have to have TIMI-3 flow. This is my first question. My second question, what are the other measures you might need to do in such a case? Like, for instance, if this patient had anemia, the hemoglobin was 8 or less, would you give blood here? Yes or no?
Okay. So first question, if we should, what should we do in terms when you have total occlusion, right?
Yeah.
Yeah. Okay, so if you have total occlusion, you definitely have to do an intervention, especially if it's the prox LAD. You can always start with wiring, balloon it, and do cutting balloons. If you have TIMI-3 flow, I think you want to decide to stop. I think you can stop. If you don't have TIMI-3 flow, then you stent proximal. Start by the proximal part, but make sure that you have quote-unquote healthy-looking vessel. Cover 10 millimeter proximal to that. If you want to leave dissection, you can leave dissection distally if you have TIMI-3 flow. But if you don't have flow, you can balloon it, see if you restore the flow, and then you decide to stop. But in the case with extensive dissection, where large territory is affected, I will not leave it without good flow. In terms of blood transfusion, hemoglobin of 8, I think 8 is acceptable. I will not transfuse this patient.
Great, thank you very much. We'll allow only one last comment from Dr. Musa Akbar before we go to the next presentation.
Yeah, thank you, Dr. Abdullah, for the nice presentation. In the PCI, if you do a PCI, I think with this intramural hematoma compressing on the stent, the likely that might be malposition. So the recommendation to repeat the coronary angio in 4 to 6 weeks, better more than 35, because this is the time, 35 days, where the healing will occur, and then you re-imaging to expand the stent. Otherwise, malposition will occur. Thank you.
Thank you.
Thank you very much, Dr. Abdullah.